Okay, now, obviously this was a big topic and we wanted to cover this, but I think a lot of times one of the issues that I sometimes have from just like leaning and reading and studying and constantly like doing your charts and everything is back pain, which is like a cervical issue that you may have. And that's, the population in US probably have more lower back pain than cervical, obviously, right? Statistic wise. Do you see more lumbar and thoracic than cervical?
Yeah, so it's almost a 3-to-1 ratio. About 75% of the population will have lower back issues, 25% will have neck issues in that group.
So when somebody comes to you with neck pain, what are some of the diagnostic tools? What are some of the risk factors? How do you basically go to diagnose them?
Sure. So when people come in with neck pain, again, it depends on how long and what's the cause. You know, if someone was in a car and they got rear-ended and they have acute neck pain, that's called whiplash. We know from natural history studies that usually goes away in about 6 weeks' time. If you were to do an MRI, you might see muscle inflammation or tendon inflammation. Most of those patients get better with Advil and a little physical therapy. If the neck pain has been going on for longer than 3 months to 6 months, we start getting worried about more structural issues. And the key trigger that leads to more imaging is if the pain is going down the arm, shooting down the shoulder blade, causing numbness or weakness. Then we get concerned that it's not just muscular or arthritic neck pain, but disc compression on a nerve. And that's the red flag to do a further workup.
And is MRI the best test that we use to diagnose these cervical images and herniated discs?
It is. MRI allows us to look inside the body. There's no radiation. It's all magnets. And it allows us to see the discs, the nerve, the spinal cord, and it's the most definitive way to evaluate these issues.
Now, one of the reasons why this is important, because if you look at some of the images that the nerve innervation that comes from the cervix, actually whatever comes from neck would affect all the lower part of your body. So starting from your arms and all the way down to your lower extremities. In my field, obviously, Sean, we see a lot of these lower back pains with the S1, S2, S3s that can affect the bladder. Sometimes they cause like incontinence, bowel issues, etc. But I think with neck pain, you would see more of arms and legs and the lower extremities. Show us some of the anatomy of the cervix, and I want you to describe exactly what's going on and how this is different than the lower back.
Sure. So you're exactly right. Pressure in the neck from a disc can hit a nerve in the neck that will cause pain down the arm into the thumb or the hand. Pressure on the spinal cord can affect the whole body.
Right.
So there's a differentiation between a disc that's hitting a nerve or a disc that's hitting the spinal cord. If the disc is hitting the spinal cord in a severe way, it can even lead to leg dysfunction, imbalance, leg weakness, bladder dysfunction in severe cases. So that's a differentiation that we look at.
Any vascular issues, like if you have any carotid problems or you don't have enough blood flow to the area, that can be similar to like neck pain that people need to worry about and not ignore?
Very rare. That's more likely to cause a brain issue than a cervical spine issue. That would be very rare.
Okay.
But the neck is a little bit of a mini lower back in the sense that, actually this is probably better. The discs are smaller. Instead of being curved like that, the neck tends to be curved, well, similarly, more neutral or lordotic. The spinal cord is in the spinal canal. The discs are in the front. The joints are in the back. And either the disc, the most common issue is the disc from the front pushing backwards, hitting the nerve of the spinal cord. The spinal cord sits in the middle of the spinal canal like that. And anything from the front, a piece of disc that pushes to the back, can impinge on the spinal cord or a nerve and cause the issues we talked about.
That's as a result of just chronic pressure, or is it from like trauma, or what exactly causes it? Why would the disc start moving from front to the back and press on that nerve? Or is it just from like just bad posture or like?
It's multifactorial. The occasional patient who has a trauma from a fall might have or a car accident might herniate that way. But much more common is just the wear and tear of daily life. Genetics is a huge factor. Some people are more prone to herniations than others. Many of my patients have family members, siblings, or parents that have had a herniation. Someone who played sports when they're younger, maybe they played football or did gymnastics and took a lot of repetitive trauma to the head and neck without realizing it, just micro injuries that ultimately when they're 30 or 40 manifest as a herniation. Realize. So things can build up over time. The postural issues and the body weight issues more affect the lower back. With the neck, it's more genetics and wear and tear.
Now this poor guy, is in deep trouble. I've been playing with his spine for a while. I don't know if I broke this or not, but you've been fixing some of this like cervical stuff. Explain to us, is this a very similar operation as you do with the lumbar and lower back, or a little different?
So there's a few different surgeries we do in the neck. Can you hear me, that little one there?
This guy.
The second one. More commonly, we end up doing most neck surgery from the front because the disc is in the front. So we'll actually come into the neck, we'll take out the disc. That allows us to look at the spinal cord and take any pressure off the spinal cord, and then we replace it with an implant that takes the place of the disc. And that allows us to decompress and stabilize the cervical spine and most importantly, relieve the nerve pain.
Now, the new discs that you guys replaced it, what is it made out of?
Well, there's different types of implants.
See, I'm learning also. It's not just for the patients. I'm actually learning a lot myself. So what do you replace them with?
So there's different types of implants. We use a combination, quite often titanium implants that can actually integrate with the bone and join the bone. There's new technologies, plasma spray technologies, and even 3D printing technologies that allow the implant or the cage to integrate with the bone and heal with the bone. And then there's metal plastic parts for disc replacement, where you can create a mobile situation where it imitates some of the normal motion of the disc.
And how long does it last? Is it the number of years, or do they need to be replaced? Or
So if we implant a cage device and fuse the space, once it's fused, that lasts a lifetime. It doesn't need to be replaced. With the newer technologies and disc replacement technology, we don't know enough about them yet in terms of the mobile bearing, how long that will last. We know in the hip and knee literature that 15 to 20 years is the lifespan. We'll see in the neck how it plays out over the next 10 to 20 years.